All righty. Hello, everyone. Welcome to Grand Rounds. So first up, we have Dr. Charlotte Starling, who studied biology at Loyola Marymount University before earning her master's in medical anatomy from the University of Nebraska. She then went on to complete med school at Jacobs School of Medicine at SUNY University in Buffalo before coming here for IM residency. Now in her third year, she's been an active member of the Washington University Teaching Physicians Pathway, and she's applying into cardiology. Please join me in welcoming Dr. Charlotte Starling to the podium.
All right. Thank you all for coming to my talk. I'm going to be talking about the balloon pump and Impella evolution from development to contemporary use. My talk is divided into three sections. First is the evolution of the balloon pump. Next is the evolution of the Impella family. And then we'll talk about the path to phenotype-driven mechanical support development and management. I have several objectives. The first is for you to be able to describe the key stages in the development of the balloon pump and the Impella. The second is to identify the challenges that complicate randomized controlled trials in temporary mechanical support and cardiogenic shock. And lastly, to explain how patient phenotyping and advanced analytics can enable the tailored therapy for cardiogenic shock. My general goal is to give you an appreciation of where these devices came from that we see very commonly in our CCU, and also to share the difficulties that have been faced in showing their therapeutic benefit, and to hopefully help you see a path forward. So I wanted to start quickly first with reminding you what a balloon pump actually is for those of you who haven't rotated in the CCU or have done so a while ago. The balloon pump is a device that uses a concept called aortic counterpulsation as a method for unloading the left ventricle and augmenting diastolic pressure to improve coronary perfusion. It offers about 0.5 to 1 liter of additional cardiac output, can be inserted via the femoral or axillary arteries, and it's used in our CCU most often to treat patients in cardiogenic shock and also to support patients who are awaiting heart replacement therapies. The Impella is different in that it sits directly into the left ventricle. It's a microaxial continuous flow device that directly and continuously unloads the left ventricle and propels blood into the aorta. It offers variable levels of support between 2.5 and 5.5 depending on which device is used. Can be inserted percutaneously via the femoral artery or by surgical cut down into the axillary artery. In our CCU, again, it's used to treat patients in cardiogenic shock, support patients who are awaiting heart replacement therapies, and also to help with protective procedures like protected PCI. To jump into the history, I wanted to start first with a quote from a paper by Adrian Kantrowitz in 1953 that describes what he believes is a good temporary mechanical support device. First is effective application with minimal surgical manipulation. Second is the capability for aiding the coronary and peripheral circulation intermittently or continuously for days. Significant support for the ischemic myocardium by reducing its work. And then simplicity of initiation and maintenance for widespread use by minimally trained personnel. And jumping into the 1950s, which is where this really started, was the discovery and appreciation for counterpulsation by the Kantrowitz brothers. So Arthur Kantrowitz was a physicist who had interest in fluid dynamics, and then Adrian, his brother, was a thoracic surgeon. They aimed to combine their interests to pursue the development of the artificial heart, and one of their primary interests was specifically towards developing methods to enhance the coronary perfusion. In 1953, working together, they found that it was possible to pulse aortic blood into the coronary arteries during diastole, which is our common understanding of what diastolic augmentation is. On their path to developing multiple inventions within the cardiac space, they developed the intra-aortic balloon pump. So in the early 1960s, the concepts of aortic counterpulsation were applied to build mechanical support devices that use that concept to improve coronary circulation. One of the first ones was the arterial counterpulsator by Roy Claus and Dwight Hankin. They basically established arterial access through the femoral artery, and their device would remove blood during systole and then replace it during diastole in an effort to enhance the coronary perfusion and reduce myocardial demand. And so the machine kind of looked like this, but ultimately the feasibility of that device was limited and ongoing efforts to build a different device ensued. And that brought us to the actual balloon pump. So this came out of the Cleveland Clinic in 1962. This group used latex tubing tied around a polyethylene catheter with multiple side holes by which the balloon was inflated during diastole and then deflated during systole. It was inserted into the carotid artery, and then they used an EKG trigger to help time the actual device. And then to determine the effect in the arterial system, they placed sensors inside the arteries to look at the pressure in an unsupported heart versus when the device was actually pumping. And what they found was that when the balloon pump was actually pumping, there was augmentation of diastolic pressure and then reduction in end-diastolic pressure, which is the familiar waveform that we see with our balloon pumps. An additional aspect of their experiment was to show that the device pumping enhanced coronary circulation. So what they did was they inserted the device into human cadavers 30 minutes after death, and they initiated pumping. And what happened was when pumping was initiated, they found radiopaque dye entering into the coronary circulation, which they point out at number 3 here. They identified 4 main benefits to using the balloon pump in their conclusion. 1 was that no blood was handled outside of the body. 2 was that only 1 vessel was cannulated. 3 was that no blood was needed for priming the device. And then 4, the device is very simple. And if we think back to Adrian Kantrowitz's description of a good mechanical support device, this device required minimal surgical manipulation. It supported the coronary and peripheral circulation, it reduced myocardial work, and it was simple in initiation and maintenance. And so really it was a slam dunk. In 1968, with further development of the balloon pump, Adrian Kantrowitz actually got to insert the very first balloon pump into a 45-year-old woman in cardiogenic shock. And they describe this woman who's in distress. She's ashen, cold, she has jugular venous distension. And I have here a picture of Elizabeth Banks from the AHA Just a Little Heart Attack skit to model our 45-year-old woman. And so the device was inserted via the femoral artery, and it was positioned in the thoracic descending aorta, similar to how it would be positioned now. The device not only allowed her to be weaned from vasopressors, but she was ultimately able to recover and leave the hospital. And Elizabeth Banks went on to have a very successful career as an actress. The initial case was followed by a larger case study that showed 30 patients with successful treatment of cardiogenic shock using the balloon pump. And those initial successful experiences with the balloon pump paved the way for a balloon pump to be used in post-cardiotomy shock. And there were 2 important trials that came out, one in 1973 and one in 1976, that described the balloon pump being used to wean patients from cardiopulmonary bypass. So the first is by Buckley, who showed a cohort of 26 patients who were initially unable to be weaned from cardiopulmonary bypass. 88% were able to be separated with the help of a balloon pump. The balloon pump was implanted anywhere from 36 to 168 hours. A second study is a smaller case report of 4 patients with post-cardiotomy shock who had the help of a balloon pump and were able to ultimately have improved hemodynamics and leave the hospital. In 1980s and 1990s, there was increased use of the balloon pump and expansion of indications that really started from the first report of percutaneous placement of the balloon pump. That was quickly adopted by invasive cardiologists and used for patients with coronary artery disease that was unresponsive to medical therapies. And from there, the FDA indications expanded for balloon pump, and it was increasingly adopted. In 2000s, began a lot of the large randomized controlled trials regarding balloon pump use in acute myocardial infarction-associated cardiogenic shock. One of the first ones is the CRISP AMI trial that looked at around 300 patients at 30 sites who experienced anterior STEMI without cardiogenic shock. They compared a group who received just primary PCI in comparison to a group that received balloon pump therapy prior to PCI and then continuation of balloon pump therapy for 12 hours after that. And they found that mean infarct size measured by cardiac MRI was not statistically significant between groups at 30 days. Additionally, they found that there was no difference in adverse events or mortality at 6-month follow-up. There were a couple of important aspects to this trial to consider. One is that balloon pump placement only delayed primary PCI by about 10 minutes, which highlighted its feasibility. And then the second is that they point out that the potential protective effect of left ventricular unloading with balloon pump may have occurred too late, given that most of their patients presented with ischemic times longer than 3 hours. Another really important trial is the IABP Shock 2 trial that aimed to identify the effect of balloon pump treatment in acute myocardial infarction-associated cardiogenic shock. They randomized about 600 patients to balloon pump versus standard of care. All patients were expected to undergo early revascularization with primary PCI or CABG. They found no difference in 30-day mortality or secondary endpoints, nor did they find any difference in adverse outcomes or process of care measures. And that was a really important trial because after that came out, there was a decline in balloon pump use. This is a study out of Australia that talks about balloon pump use at their site. Over 1,000 patients presented in this time frame, and it really dropped off after IABP Shock 2 came out. One of the more recent trials, the ALT-SHOCK 2 trial, aimed to determine the benefit of balloon pump support for heart failure-associated cardiogenic shock. They had about 101 patients with SCAI stages B, C, and D who were deemed suitable for heart replacement therapy and divided them into a balloon pump versus standard of care group. They found no difference in 30-day mortality, nor was there any difference in survival or successful bridging to heart replacement therapies between groups. There are some criticisms of this trial. One is that it's a pretty small sample size. Second is that they had a pretty large portion of SCAI stage B patients, meaning patients who are in beginning stages of cardiogenic shock. And then lastly, there was a 13% crossover from the standard of care group to the balloon pump group. Ultimately, based on the 2025 guidelines, the use of balloon pump to treat AMI-associated cardiogenic shock has been downgraded to a class 3 recommendation, indicating that it doesn't have any benefit. But there are a couple of reasons why balloon pumps still might be used. One is that there's generally a lack of evidence for other alternative temporary mechanical support devices. Two is that there may be lack of availability at certain hospitals for mechanical support devices in general, and balloon pump may be the best thing that they have. Third is that the cost difference between balloon pump and other mechanical support devices is quite different. Balloon pump costing between $800 to $1,000, and things like Impella costing around $25,000 to $26,000. And then lastly, in general, for patients in cardiogenic shock, we have a lack of evidence-based tools for the rapidly decompensating patient. Jumping into the history of Impella, it starts way earlier in 200s BC with Archimedes, who is a Greek mathematician. Archimedes is well known for the development of the Archimedean screw that was used in agriculture as a water pump in Egypt. And little did he know then that the invention he made way back then would be used to treat patients in cardiogenic shock now. Many years later, in 1970s and 1980s, Dr. Richard Wamper gained inspiration in Egypt on a medical mission in 1975, where he observed these water pumps powered by the Archimedean screw. And given his interest in artificial hearts and LVAD design, he wanted to make a pump that applied Archimedes screw principles to move blood from the left ventricle to the aorta. It was an axial blood flow device that pumped by rapidly turning about an Archimedes screw 25,000 RPMs. It was made of stainless steel and then attached to a silicone rubber inflow cannula. The actual pump was positioned across the aortic valve and sat in the left ventricle. It was able to supply flow rates of 3.5 to 4.5 liters per minute, and then it could have been inserted either by the femoral artery or into the ascending aorta directly. And this is a picture of Richard Wamper on the right side of the patient, and then this is Dr. Fraser, who's the surgeon. And in 1988, the first hemopump was implanted into a patient at Texas Heart Institute. And it was a pretty important moment in history because it made the first page of the New York Times in this tiny little article in the corner that a tiny heart pump saves its first life. And there's a quote here by Dr. Fraser that says, "A device this small to take over the functioning of a human heart is astonishing." And I think so. But in the 1990s, the hemopump kind of fell out of favor in the US, and efforts kind of shifted over to Germany to build a better device. And Dr. Thorsten Seiss, who aimed to make the hemopump more effective through different design trials, made a couple of changes. He shortened the rotating impeller rather than using a long screw. He optimized shearing forces and then developed a pressure monitoring system. And Dr. Seiss is now credited as the inventor of the Impella. In the early 2000s, the use of Impella as assisted intercorporeal circulation actually helped promote its approval. So Dr. Seiss's device was used for a time as a biventricular support during cardiac surgery, and it was a new method of intercorporeal circulation that offered a more physiologic hemodynamic support compared to extracorporeal circulation. And studies regarding the Impella's impact used in this indication found that there was reduced myocardial oxygen consumption reduced infarct size that was proportional to the degree of unloading, and then improved hemodynamic markers like MAP, cardiac output, and then reduced local ischemia during cardiac surgery. And then in 2008, the indications for Impella also expanded through the FDA, with 2008 being the FDA approval for Impella 2.5, followed by the approval for Impella CP in 2012. A couple of important trials to talk about here. First is the ICER shock trial, which aimed to determine the safety and efficacy of Impella 2.5 in comparison to balloon pump. They had a patient population of about 25 patients with acute myocardial infarction associated cardiogenic shock. They randomized them to balloon pump versus Impella 2.5, and while hemodynamic support was greatest in the Impella 2.5 group, there was no difference in 30-day mortality. Both had mortality at around 46%. And then what they did find is that the Impella group had higher rates of hemolysis, and those patients required more blood transfusions. Going on to the PROTECT 2 trial in 2012, this is a prospective international multi-center trial that aimed to compare use of balloon pump versus Impella 2.5 in patients with symptomatic 3-vessel disease or an unprotected left main disease with reduced EF who were undergoing non-emergent high-risk PCI. They found again that hemodynamic support was greatest in the Impella group, but there is no difference in mortality at either 30 days or 90 days. What they did find is that although there is no difference in 30-day major adverse events, there was a significant reduction in adverse events at 90 days in the Impella arm. There were also fewer revascularization events in the Impella arm as well. Going on to the IMPRESS trial in 2017, this was a head-to-head comparison of Impella CP and balloon pump. They randomized 48 patients with very severe acute myocardial infarction-associated cardiogenic shock. All patients were treated with inotropic vasoactive medicines, and then everyone was mechanically ventilated. They found that 30-day mortality was not statistically significant between groups, 50% and 46% at 30 days, and then at 6 months, both were 50%. It's important to recognize, though, that this trial studied a very, very sick patient population. Not only was everyone mechanically ventilated, but 92% of their patients had out-of-hospital cardiac arrest. 48% of them had time to ROS that was greater than 20 minutes. So although this was kind of a neutral trial, it's important to recognize that their trial results represent a very, very sick patient population. And then going on to the danger shock trial, which is the first trial to show benefit in temporary mechanical support. They compared use of Impella CP and standard of care in patients with STEMI-associated cardiogenic shock. They randomized 355 patients into a group that received Impella CP and a group that just had standard of care. There was a significant difference in mortality at the 6-month follow-up period in terms of mortality, with 45% mortality in the Impella CP group and then 58% in the standard of care group. It's important to recognize that this trial implemented more strict enrollment criteria and exclusion criteria that resulted in a more homogeneous patient population. They excluded patients who had out-of-hospital cardiac arrest and patients who had overt right heart failure. They also studied patients, they stratified patients into anterior versus non-anterior STEMI. And Impella is now a Class 2A recommendation for patients with STEMI and severe refractory cardiogenic shock. Unfortunately, despite an innovative path for both of these devices, it's really hard to ignore the neutral or sometimes negative trials that seem discordant with our clinical experience. I know from my own experience in the CCU, and I'm sure many of my co-residents would agree, that we've seen patients who are decompensating where the device was really what made the difference. And it's hard to see trials that don't reflect that clinical experience as well. And there are a couple of reasons why that might be. One might be opaque inclusion criteria. Another would be small sample size. And then lastly, heterogeneity in cardiogenic shock, which we'll spend some time talking about. It's also important to recognize the differences in trial design for the danger shock trial. They used more strict enrollment and exclusion criteria, and they identified a targeted patient population that showed a true benefit. But with strict inclusion and exclusion criteria, they may limit generalizability of those results. And taking a second to talk a little bit more about the heterogeneity in cardiogenic shock, it's increasingly recognized that this exists, and there are multiple factors that contribute to heterogeneity. First being severity. We can think about severity within the SKY framework. It allows us to classify and stratify patients based off of evolving clinical data and putting them into buckets of severity. For those who are not familiar with this pyramid, A represents the patients who are just at risk for cardiogenic shock, meaning the least severe. B is beginning cardiogenic shock, followed by classic, decompensating, and the patients who are in extremis. Next would be acuity and etiology, and it's important to consider patients with acute etiologies like acute myocardial infarction, who may not have the hemodynamic resilience or compensatory mechanisms that patients with more chronic etiologies have, like patients with acute on chronic heart failure. In those patients who have more acute etiologies, perhaps temporal mechanical support needs to be considered more upfront. Next would be ventricular involvement, and this is also important to consider. It can dictate which mechanical support devices or which pharmaceutical therapeutics may be most beneficial. Not all temporal mechanical support devices are able to support both ventricles or the right ventricle. Another one would be hemodynamic profile and shock pattern. Mixed shock etiologies in this cardiometabolic phenotype are increasingly recognized but notoriously understudied patient populations, and we don't know the clear benefit of temporal mechanical support in that specific patient population. Lastly, on my list would be anatomic considerations, which would dictate which temporal mechanical support devices a patient is eligible for. For example, patients with left ventricular thrombi are not Impella candidates. And my goal in showing you this slide is for you to think back through all of the patients you've taken care of in cardiogenic shock, think about their unique presentation pattern and how all of those unique aspects dictated the management decisions. And then think into the future and think about how many different permutations you can make for patients in cardiogenic shock. It's kind of overwhelming to consider each of these as a patient population to be studied, but it's definitely important to think about. There is research going on into this in order to identify cardiogenic shock phenotypes that might inform trial design in the future and enable management algorithms tailored to specific cardiogenic phenotypes. This group, led by Zweck, identified 3 distinct cardiogenic shock phenotypes with variable mortality rates using machine learning based off of laboratory and hemodynamic parameters. They identified a group that they called non-congested, a cardiorenal group, and then a cardiometabolic group. What they found is that each phenotype was reflective of a maximal SKY stage, with the non-congested and cardiorenal phenotypes reaching mostly SKY stage D, and then the cardiometabolic phenotype that reached mostly SKY stage E. Their phenotypes also correlated with mortality in that the non-congested phenotype had the lowest 30-day mortality in comparison to the cardiometabolic phenotype that had the highest mortality. Most relevant to our discussion is the impact of these phenotypes in temporal mechanical support choice. The initial use of Impella was associated with the lowest mortality in their non-congested and cardiometabolic patient populations in comparison to the cardiorenal phenotype that had the lowest mortality with balloon pump. And while this data is not statistically significant, it's important to recognize that differences may exist in that it's important to consider the choice of temporal mechanical support within the context of the phenotype. I have a few take-home points here. First is that Impella and balloon pump grew out of a really remarkable journey of innovation. The gap between our clinical experience and randomized control trials is likely reflective of the heterogeneity that exists within cardiogenic shock populations. And lastly, analytics-driven phenotyping may be able to enable tailored use of these therapies, aligning treatment with the patients who are most likely to benefit. I have several acknowledgments. Dr. May has been an incredible mentor to me throughout my internal medicine residency. I've had several wonderful teachers in the CCU, including the cardiology faculty and then fellows as well. I'd like to also thank Dr. Stephen Chang, who's been a great support for me as well, and then the chief residents, my co-residents, and then family and friends as well. I have my references here, and I'm happy to take any questions.
That was great, Charlotte. We'll open it up to a couple minutes of questions. Yes, Dr. May. No.
Charlotte, spectacular job. This was really a high-quality presentation. I'm very interested in kind of how you ended the discussion or your presentation on sort of phenotyping for cardiogenic shock. The work by Zweck
That's a great question. I think that there's a lot of different elements. SWEC use mostly hemodynamic parameters, laboratory parameters, but I think that in order to truly identify perhaps maybe even more phenotypes, you could make it more specific and include things like presenting sky stage. You could include things like ventricular involvement, etiology, whether you define that as acute or chronic, may be helpful in defining a phenotype as well. Shock pattern is increasingly recognized, although I think it's somewhat difficult to kind of parse that out as to what the shock type is, but grouping them into a mixed shock phenotype or vasoplegic phenotype versus the traditional cardiogenic shock vasoconstricted. There's a lot of different permutations, but I think that it would be helpful to include perhaps more so that you can identify specific patient populations. Mm-hmm.
Go ahead.
It can be challenging to recruit patients for shock trials, right? Like you come in an arrest, how are they going to consent? And how are you going to randomize them to a therapy like a balloon pump when you have all this data showing the class B indication? Understanding the caveats that you mentioned are very true. We definitely still see benefit with balloon pumps and Impellas, even if the trials seem to be more neutral about it. So how do you overcome that challenge of having clinical equipoise to do that trial in patients who can't really consent for themselves?
So, oh, sure. The question was about how you recruit patients for these trials, knowing now that balloon pump is no longer really recommended. Is that?
That and some of the trials for Impella aren't that impressive.
Right. Yeah. So I think it's really challenging. I think that it's a good question. I don't have a straight answer for you, but I think that now that we have all these negative trials, I think people are increasingly recognizing that we have heterogeneity in our patient population. Maybe we can't trust, the trials for everyone, because they include such a broad group of patients. And so I'm hoping that in the future, when we have more targeted trial designs, that will change. That's my hope.
We'll do one last question. Emily?
Hi. Oh, I'm sure there are. I know that there are Impellas that are in development that are hopefully going to last longer. I can't remember the name of it, but I know that there's one that's being considered for patients to eventually go home with, though I'm not sure where we are in how long that's going to take exactly. But I'm hopeful at least that there are more trials going on to develop more devices, definitely. Mm-hmm. Thank you.
Great job. Thank you, Charlotte. Next up, we have Dr. Matthew Samaro. He earned his undergrad degree in bio from the University of California, San Diego, before attending Indiana University School of Medicine for his MD. He then came to WashU for his internal medicine residency. Now in his third year, he is preparing for GI fellowship. Let us welcome Dr. Matt Samaro to the podium.
Should be just right here on the, there we are.
All right, everyone, thanks for coming this morning. As mentioned, my talk is going to be on alcohol-associated hepatitis, touching a little bit on management, some of its outcomes, and then hospital utilization, and the importance of palliative care. And so a little bit about me. As mentioned, from California, Bay Area, and went to San Diego for undergrad. I am a really large soccer fan, particularly of English football, and so oftentimes you'll see me in the hospital wearing some sort of Manchester City gear. Recently I got into, you could call it urban gardening, and so we have just about half of our outdoor deck with a couple of vegetables, and then not pictured is the other side, which equally as many. and then a couple of pictures here at the top as well of me and my girlfriend Abby, who's one of our general surgery residents here, and we matched together here just a couple years ago. So some objectives that I wanted to touch on for the talk today is define and understand the prognosis of alcohol-associated hepatitis, touch on its epidemiology and some recent trends, quickly review its current treatment standards, and then for the second half of the talk about the healthcare utilization and then the importance of palliative care for this patient population. So briefly on epidemiology, this was from a paper that from 2011 to 2017, they used the national inpatient sample and looked at patients over this time period using ICD-9 and 10 codes. And they were really interested to see what the total trends were in the amount of hospitalized patients with alcohol hepatitis. And they noticed that the gross number increased per year, and that this was statistically significant, although it was a pretty slow increase over this time period. And by and large, that the main reason for the increasing incidence is from increased alcohol consumption. And then following that up, there was a paper in JAMA in 2024 titled "The Epidemiology and Outcomes of Alcohol-Associated Hepatitis, particularly for adolescents and young adults." This study was conducted in Ontario, Canada. They took patients from 2002 to 2022, and they collected data on 3,300 young adults with an age range of 13 to 39 with their first presentation of alcohol hepatitis and no underlying cirrhosis. And what they ended up finding was that the incidence over this time period increased by about 8% per year, which was clinically significant. And then also, along with this, there was a pretty significant mortality. And so the associated death rate at 1 year was about 7%, 19% at 5 years, 29% at 10 years, and then 48% at 20 years, despite this being a really young population. And then some common risk factors for alcohol-associated hepatitis. By and large, number one is heavy and sustained alcohol use. That sets the stage for the development of this disease process, and then ultimately binge drinking is typically what pushes patients over the edge. There are papers now looking into genetic predisposition for the development of this hepatitis. Malnutrition is also very common. With this heavy alcohol use, patients end up taking in a lot of their calories via what we call empty calories, and this leads to a lot of micronutrient deficiencies and predisposition. And then there's been various comorbidities identified, particularly metabolic syndrome, obesity, and then if a patient has had a previous viral hepatitis as well. Most of us are very comfortable with the clinical presentation of this disease process. I included a chart here that goes over the common ones, but by and large, what I highlighted in blue is what really stands out the most. Typically, we associate it with rapid onset jaundice and then tender right upper quadrant pain. Some laboratory values that really stand out in this disease process are elevated LFTs, particularly with an elevated AST, and oftentimes these numbers are in the 300 to 400 range, as well as a direct hyperbilirubinemia in INR. And then importantly, this disease process can overlap with decompensated liver disease, but these are two distinct phenotypes. And then I left a note on the side going over biopsy. Typically, this can be avoided if you get these stereotypical labs. You do a really good job examining the patient and getting their history, but if there's diagnostic uncertainty, this can be pursued. And then touching a little bit on some of the prognostic indicators that we have for this process and our treatment modalities. As physicians, we try to find ways to make medicine black and white. Unfortunately, for this disease process, it's very gray. We've developed what's called the Madry discriminant function to help define which patients have a severe phenotype versus a more mild or moderate. We use the MELD score, in this disease process as well, even for patients without cirrhosis, as this can help guide transplant evaluation. And then for treatment, we use steroids in select patients, and we've developed a Lyle score to see whether or not patients are responding appropriately. And then I want to draw attention to the diagram on the right. The best prognostic models that we have is actually a combination of the MELD and the Lyle score, and so this is depicted over on the right. On the top figure, it is the 2-month mortality using the Lyle and MELD, and then on the bottom is the 6-month. And then, as I mentioned, previously I mentioned steroids is what we use for treatment, but by and large, the treatment for this disease process is supportive care. Steroids have their associated risks, and if we don't screen patients appropriately, it can lead to some pretty significant decompensation. Malnutrition is very common, and this underlying malnutrition worsens outcomes, and so it's recommended to have a nutritionist involved in these patients' care, and currently recommended for about 1.5 grams of protein per kilogram per day for these patients. And then it's also important to manage a lot of the associated complications of this process, such as ascites, encephalopathy, and renal dysfunction. Lovett et al. Looked into the rate of infection, particularly in patients with a severe presentation or a MADRI greater than 32. And what they found was that 25% of these patients on admission already had evidence of infection, and then 24% ended up developing infection after the start of steroids. And then in this Kaplan-Meier curve that they created, it showed the 2-month mortality for the patients that did not develop infection versus those that did. And as you can see, there's a pretty stark contrast between the two groups. And then also, going along with the treatment is really we have to manage any underlying alcohol use disorder. Abstinence currently is the best and most effective long-term intervention we have for treatment of alcohol use disorder. It's also important that these patients get really close outpatient follow-up. And then we do have a couple of approved medications to try to treat alcohol use disorder. Unfortunately, naltrexone in the acute setting, as it's hepatically cleared, is not recommended, but acamprosate is renally cleared, so as long as their renal function is intact, that is an adequate option to start with. And then I have on the right a meta-analysis from Maisel et al. In 2013. They looked at data for the use of acamprosate and naltrexone for management of alcohol use disorder. And so the image on the left is, or on the diagram, the top studies are for naltrexone, and on the bottom is acamprosate. The picture on the left shows the different effect sizes for complete abstinence from alcohol, and then on the right is the effect sizes for heavy drinking outcomes. And as you can see, acamprosate has a little bit of better evidence for complete abstinence, and then naltrexone for avoidance of heavy binge drinking, but both are totally appropriate medications for management of alcohol use. Right now, the mainstay of treatment is with steroids. Before we use steroids, it's important to really screen for any infectious complications and have a risk-benefit discussion. Current standard of care is prednisolone at 40 milligrams per day. Oftentimes we can substitute this for prednisone, although the majority of the trials, like the STOP-AH trial, did utilize prednisolone, and so that, per the guidelines, is the standard of care. And then we use our Lyle score to see whether or not patients are responding appropriately. There are studies trying to see if day 4 versus day 7 can be utilized, particularly because this patient population is so susceptible to infections. And so if we're seeing that a patient is a non-responder, they're starting to show evidence that maybe using the day 4 is adequate for these patients. And then for severe presentations with a MADRI greater than 32, use of N-acetylcysteine with steroids has shown to improve a 1-month survival, but beyond that, the benefit starts to drop off. And then there's been studies looking into new therapies for this disease process. I listed just a couple here. The top one is a phase 2A study. FXR is a farnesenoid X receptor, and it's been found in mice models to reduce steatohepatitis and so they're currently recruiting patients for their 2A. And then the bottom one is a phase 2B study looking at DIR-928, which is larsucosterol, which is a DNA methyltransferase inhibitor. Currently in a 2B, their primary endpoint is 90-day mortality or liver transplant rate. And then unfortunately with this study, they did not meet this primary endpoint, but there are ongoing studies looking into this medication. And then quickly going into some healthcare utilization. The short-term cost for this patient population is very high, and it depends on where they present. And so this study, looking into the short-term cost in different clinical settings, they analyzed patients who were seen in the outpatient setting, in the emergency department, and in the inpatient setting. They used Optum's Clinoformatics Data Mart, and they collected data from 2016 to 2023. What they ended up finding was that for all patients, once they were diagnosed with this disease process, with all the workup and treatment required, the cost was fairly significant, and then easily the largest cost burden was on the inpatient population. And they found, in subgroup analysis that the driver for these costs were typically the comorbidities associated with alcohol use and metabolic syndrome, and then also included some patients that qualified for liver transplant. And then expanding upon this, kind of looking at intermediate costs for this group over about 5 to 6 years. This was a paper looking into mortality and costs. They collected data from 2006 to 2013. They looked at 15,000 commercially insured adults hospitalized with alcohol hepatitis. What they found was that the very first year of diagnosis and treatment was by and large the most expensive time period, particularly the first 3 months after diagnosis when the illness is at its most severe. They found that the average cost for a patient in their first year was about $53,000, and the total cost per patient, or for each patient over 5 years, was about $145,000. And then for these 15,000 patients over this time span, the total cost was about $2.2 billion. And then kind of expanding upon this, there was a paper that then used this data and used a validated microsimulation model for consumption in alcoholic liver disease from publicly available sources such as the CDC, the Bureau of Labor Statistics, and National Epidemiologic Survey for Alcohol and Related Conditions, and that they found that over a little less than this 20-year period, they're expecting about $880 billion, kind of split between lost in labor and economic consumption as well as direct cost, and that the cost per year is also expected to more than double during this time period as well. And then currently the phenotype is mostly males. However, over the last 15 to 20 years, we've started to see an increase in rate of this disease process affecting women, and so they're also expected to be a larger portion of the total financial burden in about 20 years. And besides this financial cost, there's a lot of associated indirect costs as well, particularly for patients and for their family members. For patients, we have to think of unstable employment stemming from either substance use or from being in and out of the hospital and needing time off work. There's a lot of stigmatization to alcoholic liver disease, and there's a lot of associated feelings of anxiety and depression. And we recommend complete alcohol cessation and joining of support groups, but this is also is a substantial time burden for these patients. And then even for family members, we have to think about taking care of them at home, bringing them to and from hospital visits, and providing transportation. It can also take quite the toll on them as well. And so then understanding this, I wanted to see what we're doing in terms of palliative care and how it's integrated into this disease process. And so briefly, palliative care, it's specialized medical care, primarily focusing on improving the quality of life for patients with serious life-limiting illnesses. It addresses both the physical and psychosocial needs. It can address spiritual concerns for patients. And importantly, it's appropriate for any stage of disease. And then there's various components to palliative care. It's goal-oriented, it's interdisciplinary, and it's patient and family-centered. So why palliative care in alcohol-associated hepatitis? Well, early palliative care can aid in their symptom burden. As we touched on earlier, these patients have a large burden of just diffuse pain, a lot of pruritus, significant fatigue, and then a lot of mental health problems such as anxiety and depression. It can help tailor treatment towards these patient goals. Unfortunately, for the patients with severe alcohol-associated hepatitis, the 1-year mortality can be about 30 to 50%, and so it's important to get an idea of what a patient wants in regards to their treatment, and it can reduce healthcare utilization as well. And then what are some barriers to palliative care? A lot of it can stem from something as simple as provider comfort with initiating the goals of care discussions. A lot of this population can be very young, and so sometimes it can feel very premature to start bringing these conversations up. Whether we like it or not, there's a stigma to palliative care. Some more rural communities may have some limited resource or access to palliative care, and then depending on the patient's culture, there may be different expectations about aggressive treatment or wanting to pursue palliative care. And there's a pretty extensive variability in disease course. We can use all of our calculators and try to predict outcomes, but unfortunately it's gray, and then even the patients with mild or moderate can move to the severe category and vice versa. And so then I looked at papers diving into the use of palliative care in this population. On the left is a study looking at 67,000 patients from 2010 to 2014, particularly for using palliative care in patients with cirrhosis. And we saw that over this time period, there was a clinically significant change in the utilization of palliative care from about 3.5% to 6.5%. And then I wanted to see if this carried over to the population of alcohol-associated hepatitis. And unfortunately, we did not see the same carryover. The study on the right ended up looking at 68,000 patients from 2016 to 2020 using the National Readmission Database with a primary diagnosis of alcohol-associated hepatitis. And what they ended up finding was that there was no significant change over this period between utilization of palliative care. And so it was about 5.4 to 5.7%. And then they did a subgroup analysis to see, if there was any specific phenotypes for this population that led to higher uses of palliative care. And what they found was there was some association with insurance, so those that were uninsured did have a higher use of palliative care. And then at the bottom, I was showing some common comorbidities that were associated with higher utilization, the two biggest ones being localized or metastatic malignancy and a history of a prior stroke. And then I highlighted the largest one, which was patients with an elevated NAC-SLD score. And then I left its components here on the right, and this can help us picture exactly what patient population this is referring to. It includes patients with either shock, significant encephalopathy, renal dysfunction, or severe respiratory decompensation. And as we can imagine, this is really describing our patients that are in the ICU or are headed towards the ICU, so it is a very sick population. And then they, for the patients who did receive palliative care, they wanted to compare whether or not this led to more patients being admitted to the hospital or staying outside at home. And what they ended up finding was that the 90-day readmission rate for the patients that did utilize palliative care was significantly lower, with a adjusted hazard ratio of about 0.45. And then this even carried over to that highlighted group that I had on the previous slide with the much more significant presentations. as their hazard ratio was about 0.46. And so, I touched on why palliative care can be important and what it can do for this population, but what are ways in which we're actually implementing it into daily clinical care? So this was a pilot study from 2016 to 2017. Their objective in this study was to look at the impact of palliative care integrated with the hepatology department, and particularly looking at healthcare utilization, advanced care planning, and hospice enrollment. I listed their inclusion criteria. They, looking at their inclusion criteria, they also had a fairly sick patient population as well. They included patients with a MELD score greater than 20, at least one complication with liver disease, and the two biggest ones were hepatic encephalopathy and ascites. And then they also needed a hepatology approval for a palliative care referral as well. And they ended up identifying or collecting information on a little over 110 patients. And what they ended up finding was that the patients that had this palliative care referral ended up completing significantly more advanced care planning documentation. They had more psychosocial assessments completed, a higher hospice enrollment, about 25% compared to 7%. And then ultimately the patients that were hospitalized ended up having fewer mean hospitalization days. It was about 13 compared to 20 days. And then building on that, there was a longer study. So this was a 3-year quality improvement study looking to improve advanced care planning in patients with liver disease. And so they collected, or it was conducted between 2018 and 2021 at a hepatology clinic with transplant attendings and fellows. The intervention that these individuals received was a 1-hour education from palliative care on specifically advanced care directives and advanced care planning. And then they had built-in standardized or built-in templates to their EMR to help guide these conversations and standardize this process. And so this followed about 120 patients over 500 clinic visits with an average of about 4.5 visits per patient. I included this study because the most common cause of the end-stage liver disease for this group was alcoholic liver disease. And what they ended up finding was that the advanced directive completion had increased from about 8% up to about 36%. And this was mostly with healthcare proxy forms. And then interestingly, they saw that patients with not only a higher MELD score, but a higher MELD score with a combination with the etiology of their liver disease being alcohol, had the highest completion rate. And so some of the things that I want for everyone to take away from this talk is that the incidence for alcohol-associated hepatitis is rising, particularly in young individuals. Our current standard of care is management of the underlying alcohol use, providing supportive care, usage of steroids and N-acetylcysteine in a specific patient population. However, these outcomes still remain poor, and there's ongoing studies looking into alternatives. This disease process imposes high indirect and direct costs and leads to frequent admissions. Both patients and their families face high symptom and decision burdens. Palliative care is significantly underutilized. It's estimated about 5 to 6%, and that the early implementation of palliative care is the best way to direct and optimize care towards these patients' goals. And there's been a couple of pilot studies identifying ways in which we can successfully integrate this into our clinic workflow to better help our patients. And then ultimately, palliative care must be interdisciplinary in order to be successful. And so acknowledgements, being the last speaker, I wanted to give acknowledgement to the Washington University Department of Medicine as a whole, all of the chief residents and all of the co-residents for giving me this platform to speak today. And then these are my references. And then see me.
All right, thanks, Matt. We have maybe time for one question from the audience. Yes.
Wonderful talk, thank you. Just curious, in the outpatient setting, it seems like we've got a lot of history of some patients that have been admitted, but it seems like not too many show up in the hospital with this condition. I'm just curious about comorbid conditions, anxiety, heart failure, PCR, some things you may have covered it, I might have missed it, but that will increase susceptibility.
Yeah, I think, great question, and so I'll try to summarize, but a lot of these patients, they might have, episodes of binge drinking, and then curious to see what other comorbidities might lead to more successful palliative care consultation. So far, the comorbidities that have shown better association to successful palliative care utilization are if they have like any underlying malignancy, our heart failure showed like some increased utilization, but not quite as much as I would expect. Stroke showed a pretty high association, but by and large, the biggest comorbidity, if it was just alcohol or binge drinking, not great follow-up, but if they had really significant underlying liver disease and already had prior decompensations, that's when it was most successful.
All right, thank you, everyone. If you have more questions, feel free to come down and talk with our wonderful speakers.